Good afternoon, everyone, and welcome to the Community Research Academy here at Weill Cornell Medicine. You're in for a great treat. But before we get started, I just would like to introduce myself and people here at Weill Cornell Medicine Clinical Translational Science who are in the community core. So you'll get to have an idea of who we are. And then I'm going to ask you to introduce yourself to us so that we will know who you are as well. My name is Reverend Dr. Lula Mae Phillips. I'm community engagement and community resource person here at the Weill Cornell Medicine Clinical Translational Science Center. We are delighted. We are so happy that you are here because we took a lot of time to plan this course specifically for the community, for people in the community, just to go over science concepts and get you involved in things that perhaps you have not been involved in prior to this time. This is a pandemic time, this is a COVID time, and there's so many things that we as community people need to talk about. And we hope that this becomes the forum for you to talk about things that are challenging for you and things that are on your mind. I am also a minister. I have a children's church. And I'm going to tell you, I absolutely enjoy what I'm doing. I was a foster mother and I adopted 16, sometimes I forget, 17 children. And that was a lot of fun as well. So now what I'm going to ask is I'm going to ask Jeff to introduce himself and we'll go around Agnes and Allegra and Tanya. And then we're going to ask everyone who is out there who's joined us today to just share a little bit about yourselves. And we have Ms. Barbara Hormann also from the CTSC. So I'm gonna ask. Okay, Jeff.
Thank you very much, Lula. My name is Jeff Zhu, and I serve as the Director for Community Engagement and Research here at Weill Cornell's Clinical and Translational Science Center. Allegra?
Hi, everybody. My name is Allegra. I am the program coordinator here at the Clinical and Translational Science Center. And this is now my third time, I think, dropping in on the CRA course. And I'm very excited for this new chapter in the course and to get to know a lot of you as well. So thank you for joining us. And I will call on Tanya next.
Hi, everyone. Nice meeting you all. I think this is my first CRE course. A research assistant, clinical and translational science, and I'm gonna pass it along with Agnes.
I gotta unblur myself. Hello, everybody. Thank you for coming. I'm the one that's been coordinating with everybody. I'm a research assistant at the CTSC as well. I've been here for over a year now, and we've done this workshop for three series now, so it's exciting to see all the new faces, and I'm excited to see what you guys bring to the table. Let me pick on Barbara next.
Hi, everyone. I'm Barbara Hormann. I am the manager of the Outpatient Clinical and Translational Science Center. So we see adult patients who are participating in research studies. I'm a registered nurse, as I said, and I've worked at the CTSC for over 30 years.
Perfect. I guess we can go around to everybody else on the call. I guess we can start with Sheila.
Hi, I'm Sheila Davis. I'm retired from the New York City Transit Authority, and I am involved with many civic activities. I'm also the president of Church Women United in Brooklyn.
Thank you. I guess we'll go in order. Michael?
Greetings, one and all. I'm Michael Williams, and I am a member and the chair of the Bronx Community Research Review Board, and I'm looking forward to learning, participating, and interacting with all.
Thank you. Deborah.
Okay, can you hear me?
Yep.
Okay, I'm Dr. Deborah Hicks. I'm a retired teacher. I'm not sure how I got here, but I know I read something that sounded interesting and signed up for it. So I'm here.
That works, that works. Next is Betty. Oh, Betty, you're muted.
Yeah.
Hi, good afternoon. Like the previous speaker, I got the email and I started thinking about it and saying, you know, this is an opportunity to learn more about clinical research. So I am a member of the Brooklyn NAACP and I'm on the Civic Engagement Committee. So I am interested in community activities, so activation of whatever issues we need to address. So I'm here to learn.
Thank you for joining us. Next is.
Hi, my name is Philip Rojas. I live in the south of the Bronx. I'm studying at Ethnicity. Being a researcher for the past 35 years, I'm working in the public. Right now, I'm a health advocate, Holy Spirit Church in the south of the Bronx. I do outreach for the nonprofit like Bronx Health Reach, Word of Life. I just started my own nonprofit. It's called Toromonte Outreach Consultant. I'm just here on the ground. I actually have a vaccination campaign right here in the Bronx, helping my Latino community, helping getting more knowledge. And to me, I stumbled upon somebody. I said, listen, you have to take this class, this program, and you're gonna learn so much. And then again, thanks for the opportunity. And like I said again, I'm here for all my Latinos, African Americans, whoever needs to get more knowledge about what is actually happening to our community. The much knowledge that I get, the better knowledge I can pass to my community.
Thank you very much for joining us. Next is a Mezjo. I'm sorry if I butchered that pronunciation.
It's Jose Amezquita. I don't know how I got here either. I do help out on a food pantry, Pancillo Soup Kitchen in the Bronx. And the coordinator there, she sent me the link basically for my daughter. And I said, you know, I'm actually starting to do research at work. I work for a consumer product testing organization. And I test consumer products, and sometimes we have to develop different equipment and stuff. So I had to do research for that. And I said, maybe this could help me. I started looking into it, and I realized clinical research and transfer, you know, all of that. And I'm like, okay, I guess I could still learn from this course, this academy. So I'm here to learn and to help if I can.
Perfect. And thank you for joining us. And last, I think we have Victor.
Yes. Yeah, my name is Victor, of course. I'm from Brooklyn, Flatbush, in the East Flatbush section of Brooklyn. And I'm also a member of Community Board 17. So that means I'm very involved in the community. And I'm here to partake in the course.
Thank you for joining us. And I see Sandra, you just joined us. You want to introduce yourself real quick to everyone? Or she might still be connecting. Can you hear us, Sandra?
Okay, I just want to say a couple of words before we get started, because Jeff is going to start the presentation right away. I want everyone to know that you have got a copy of the syllabus. And what I'd like for you to do is, if you can, take out the syllabus and take a look at it. And on the syllabus is what you're going to see is the order of the presentations. And you will see that with each syllabus, there are several things that we're going to ask you to do prior to coming to the class, if possible. And the choice is yours. So right now, what Agnes is going to do, she's going to put a copy of the syllabus up for a quick minute. And I'll just walk you through a couple of things that I think are very important. They'll make the class much more enjoyable. And it will also help prepare you for each session. Or if you have questions or if you missed something, you can always go back to the syllabus and take a look at it. Okay, so just give us a half a second. Okay, here it is.
Wait, let me share my screen.
Oh, okay.
Okay.
All right. Now, as you can see, okay, not yet. What we have basically is you will see the dates for the class. And even though we've said Thursdays and Fridays, Thursdays and or some Fridays, all the dates are already here in the syllabus. If there's a change, Agnes will let you know way ahead of time. You have the course objectives, which is the basic elements of the things that we're going to cover in the course, but we have quite a lot. So let's go down to the first week. Hold it. Okay. Now for week 1, you're going to see Introduction to the Community Research Academy. And at that time, you're going to see the speakers. We have 2 speakers and the time limit and the material that they're going to cover. Now, the week before, so hopefully, if you've had time, you can go and take a look at some of these YouTube videos that will give you insight about the material that we are covering. So for example, what is translational research? Translational research, accelerating new treatments. So these are videos, they are very short. We made them, we chose them to be short specifically so that you wouldn't find that you're being bogged down with a whole lot of information. Now, in this, you also have an opportunity to take 2 courses. One is from the Psychological Association, and the other one is from the community. It's on community-based participatory research. Now, both of these courses are fairly long. You do not have to pay for them. You will just have to let us know that you've completed them. And Agnes is going right to those areas right now. Okay, so she's highlighted them in blue so you can see them. And when you have completed these courses, you let us know. And these courses are fairly long, but they're very informative. And they will help you with basic understanding of a lot of materials or things that perhaps you learned a long time ago and you've forgotten. And if you were in an arts major, maybe it was you never really covered stuff like that will be shared in these courses. So I'm going to ask you to take your time, go through the syllabus. If you have questions, let us know. We'll go over that material with you. But for the completion of this entire course, what we're asking you to do is to attend the program, attend all sessions, take these additional courses, and you do this at your leisure, whenever time you want. You can do it Thursday night at 2 in the morning, Wednesday afternoon, whenever you want, when it's most convenient for you. Go through it. If you have questions, ask us, okay? But take a look at the entire syllabus. Upon completion of the syllabus and of the work, you will get a certificate of completion from Weill Cornell Medicine Clinical Translational Science Center, and we'll send it out to you in the mail. When you finish this course, if you are interested and if you wish, we have special assignments and special areas that you can volunteer to become a part of in the various cores or the various departments here at Weill Cornell Medicine Clinical Translational Science Center. You can also volunteer to become a member of our community advisory board, and I'll tell you a little bit more about that as we go through the course. So if you have any questions regarding the syllabus or anything like that, you can ask me now. If not, then you're in for a treat. Jeff is all ready and he's got a lot of great information to share with you. So without further ado, Mr. Jeff Zhu.
Thank you very much, Lula. And you should all be able to see my screen now. Is that good? Agnes, is it good?
Yeah, it looks good.
Looks good, perfect. So thank you everybody for joining us today. And we greatly appreciate that all of you have an interest in community outreach and are eager to learn. I think learning is a great thing. And I think it's great that started out. I want to give you an idea of what translational research is. And it's an entire process with many different phases. And it starts out with what over here is T0 that you see is a basic science research. And that's what you think of when you think about somebody in a lab working with sort of mice or petri dishes or test tubes. That's the basic science that takes place before any clinical or animal studies. Phase 1 then is how do we take discoveries we make in the lab in order to make sure it is safe in humans. So if we use the COVID-19 vaccine as example, phase 1 trials where the first sort of to demonstrate is this, we give a small amount of the vaccine to people to make sure it's safe, it doesn't cause any side effects, and it doesn't harm them. And that's phase 1. Phase 2 and phase 3 are sort of, phase 2, rather, type 2 is phase 2 and phase 3 clinical trials. And these are to determine what dose of a particular the vaccine is needed to be effective, let's say in preventing COVID-19 infection, and what amount it should be used. And then the next phase, T3 of translational research, is translation to practice. And that's really where we are right now, where we take a new discovery, such as the COVID vaccine, and we getting people used to using it and getting medical providers to actually adopt this new policy. And then we can try and see how effective it actually is. So in this case, with their COVID-19 vaccine example, we're trying to figure out, can we convince people to actually take the vaccine? And then once people have taken the vaccine, how effective is that vaccine at preventing COVID-19? And as I'm sure all of you are aware, there are lots of challenges with getting people to take the vaccine at this point. And that's really where we look at the fourth part of the translational research process, which is translation to community. So once we've translated it into practice where physicians are recommending people take the vaccine, what is the actual impact to the communities? Are we actually preventing COVID society-wide? Are we actually, for COVID, are we actually getting life back to normal? Are we actually building up that herd immunity or preventing severe cases of COVID? So all of those would be outcomes that we could look at in the research process. And so the next thing I want to talk about is what is the Clinical and Translational Science Award. So this award was first, I started in the early 2000s, and it was based on an observation that the National Institutes of Health, so they are the largest scientific funding research agency in the United States, and they did a study where at the time they found it took about 16 years for a discovery made in the lab to be turned into a new drug or a new treatment for people. And obviously that's bad. Imagine if it took us 16 years to get a COVID-19 vaccine out, right? So clearly there's a need to speed up this process. So that's essentially why the CTSAs were created. They were designed to develop innovative solutions to improve the efficiency, quality, and impact of the process for turning observations into interventions that improve the health of individuals and the public. And so has it been effective? It's actually not too bad. Since the CTSA program was started, the average time has gone from 16 years to 12 years from discovery to treatment or drug. So it's an improvement. It's not quite where we need it to be yet, but it's definitely a lot better. And the goal of the CTSA program was to provide infrastructure to speed this process up and help it make it happen. And to date, there are 62 of us across the nation. Here's a map of US with all the CTSAs, so you can see they're all throughout the country. I wanted to briefly talk about Weill Cornell's Clinical and Translational Center and what makes us a little bit unique from the others. So there's a complicated chart here, but really what I wanted to point out is that in the middle is the administrative core and the operations committee. These are the leadership individuals who run the Weill Cornell's Clinical and Translational Science Center. And pretty unique to us is that we have an external advisory board comprised of a community member, industry experts, and faculty from other institutions that directly reviews and submits feedback that the administrative core and the leadership take into account and are required to actually follow. In addition, we also have a community advisory board that does the same. So the community advisory board, which you'll learn more about as this course progresses, is comprised exclusively of community members the vast majority of which are minorities and or female. And then finally, we also have Eternal Leadership Council and Evaluation and Tracking Committee, which also report to the Administrative Core and help provide feedback. And the CTSC itself is divided into different, what we call components that provide different types of resources to help researchers conduct their work. So for example, we have the informatics component, which provides IT and database support for various research studies. The Community Collaboration Core is this core, and you'll learn more about us in a bit. Translational Endeavors is the one that awards our grants. So we give out what we call pilot awards or grants to conduct pilot studies to test new ideas to see if they're worth examining further. We also have a group called Regulatory Methods, which handles biostatistics, research design, as well as IRB and human subject protection. So I know these are a bunch of terms I'm throwing at you. You'll learn more about each and every one of these over the next couple of weeks. Then we have hub research capacity. And this is just a fancy way of referring to the inpatient and outpatient units, which Barbara will talk more about later, as well as our research navigation team, which is a bunch of research assistants who help support and make research happen. And really our research cannot happen without them. So big props to them. And then next we have network capacity, and that's just a fancy way of saying, how do we get the CTSAs, the 62 of us across the nation to work together and collaborate on research. And then we also have two optional modules. One is for veterinary medicine, and that's the idea of how can we use studies in animals, large mammals, such as horses, dogs, pigs, in order to speed up research in humans. And then we also have a precision medicine component. And precision medicine is the idea of how do we tailor, instead of taking one treatment and applying to everybody with the same disease, how do we actually tailor treatments to a specific individual and their genetics and their environment and their medical history? And so that's one of the newer advances in medicine. And I think you'll be learning a little bit more about that later as well. And finally, we have an educational group, Institutional Career Development, and that handles two programs we have for training medical students to become researchers, and then training early level faculty members to become better researchers. And so I'll move on to talking a little bit about the community engagement research component. And really I like to tell people our biggest and our most important goal is to build trust with the communities in New York City. And we do this by disseminating health knowledge to communities in New York City. We partner with communities to offer various health services, and we educate communities such as all of you on medical best practices, or at least we try to. And then we also try to increase the engagement of New York City's communities in the research process. Because one of the traditional weaknesses of research in this country is that it's always been done from sort of a top-down level, where the researcher decides everything and then dictates how it's done. We want to change that because we recognize that's not the proper way to do things. You have to involve communities in the research process as partners and decision makers. And you have to provide a platform for participation of the historically underrepresented groups in clinical trials and research. And I think a great example of this is that there's a huge distrust of the COVID-19 vaccine in historically underrepresented groups. And that is precisely because of our history of not involving them in the past. So this is one of the big issues that we as the Clinical Translational Science Center are trying to solve. And then finally, we want to guide and support investigators with research, resources and infrastructure to make their research happen. So I'll briefly share a couple statistics about what we've done over the years. The numbers are about a year old. We're actually going to be doing our annual updates soon. So this information is for up until September of last year. And to date, the CTSC has held 834 community events, reaching over 12,000 community members across 165 sites. And the major programs I'll talk about are a free health screening program. We have an educational talks program, as well as an opioid overdose prevention program that provides education on what is an opioid and the opioid epidemic and distributes free naloxone kits to treat opioid overdoses. And then we also have various other support. And we also one thing I do like to talk about is the demographics of the communities that we serve. And the term I like to use is the majority of our participants are minorities. And what I mean by that is if you look at the race breakdown, it's about 55% African-American or Black and 12% non-Black Latino of the people that we work with. So that's, and then about 9% Asian. So the vast majority of the people we serve our programs represent minorities. And for some reason, women are a lot more interested in health than men. So about almost 70% of the individuals that we work with are female. Real briefly, this is a map of New York City with all of the community partners that our programs have gone to. So blue is our health education program. Red dots are the free health screenings we've offered. The green dots are the opioid overdose prevention program sites. And the purple ones are ones where we've done hands-on CPR training. And so the first major program I want to talk about is our heart-to-heart community outreach campaign. And so what this program is it provides free health screenings for minority and low-income communities. It helps train future health professionals, and it gets us some health data on a community that's normally very difficult to get health information on. And what we do is that we use this information to help examine what is the rate of disparities in these communities. And we've actually found a couple of very interesting things, which I'll talk about in a second. But real briefly, the services we provide at these screenings are height, weight, body mass index, and blood pressure, as well as blood tests that are done on the spot for diabetes and heart disease. We also include a full eye exam or ophthalmology exam at some events, as well as a medical consultation with one of our physicians or nurse practitioners to explain the results. And we also have registered dietitian students attend the events to give nutrition counseling. We also help people get insurance enrollment and find follow-up healthcare if they need it. And so, again, this is the map, red dots representing all the places we've held the events. And we do look at whether or not we're reaching the right communities with this program. And so one of the statistics we look at is what percentage of our participants live below the federal poverty line, which is about $21,000 a year for a family of 4. Now, this is New York City, and I can tell you that it is not possible to live in New York City below the federal poverty line by any means. And so we also look at something called what is a living wage. So living wage is defined as $65,000 a year for a family of 4 in New York City. Again, for a lot of us, I think that I don't know how a family of 4 is expected to be able to pay New York City rent levels on that much money, but that is at least scientifically calculated as what is considered living wage. Unfortunately, about 58% of our program participants do not make a living wage. So definitely, we're reaching the right communities with our program. In addition, about 27% of our participants are uninsured. One of the questions I have got asked a lot over the years is, did the Affordable Care Act or Obamacare help reduce those numbers? And the answer is a little bit. And before the ACA was passed, we had about 30% uninsured. As you can see, it's dropped these days to about 24% or so. The main issue we have is about 20% of our participants are undocumented. So the Affordable Care Act is not available to undocumented individuals. So we would never get below that 20% mark. And again, for this program, again, the majority of participants are African-American, 55%, and then Asians and non-Black Latinos making up another good percentage of our participants. Some of the interesting findings. So one of the measures we look at is something called the hemoglobin A1C, and this is a measure for diabetes risk. And one of the sort of more astounding examples we found is that over half of our participants are either pre-diabetic or diabetic. And so that for me was one of the biggest eye-openers of starting this program. I remember early on, we had one of our medical students came up to me during an event and said, so I've got this gentleman I've been talking to, and I asked him as part of the survey what he considers his health to be. And he said his health is excellent, but he's overweight, pre-diabetic, and has mild high blood pressure. And the medical student was confused. This person does not understand. Why would he say his health is excellent? At the time, I said maybe he wasn't aware But when we look back at the data, this individual, well, was definitely had above average health for his community. He had definitely much better health than those around him. And so for me, that was a real eye opener that, you can be pre-diabetic, you can be overweight and still be better, much healthier than the majority of people in your community. And that really brought to me just how great, it made me understand how great the disparities that some of the communities in New York City face. Yeah, and so and if we look at blood pressure and total cholesterol, we see similar things, where a much larger than average number of members from these communities that we serve have high blood pressure or high total cholesterol. And we've identified to date 473 new cases of high blood pressure and 827 new cases of high cholesterol. Our second major program is community interactive video conferencing, and this is our health education program. We started this way back in 2009. That was the year the iPhone was released. So video conferencing was a new thing back then. Today, it's pretty normal, especially since the pandemic. But we've kept it up over the years, and we use this to reach our community partners across New York City to provide health education, kind of like how we're presenting this course. We've held 316 events since 2009 all across New York City. And again, majority of participants are minorities, again, mostly African American or Black. One of the questions we ask people is that after you attend an event, do you plan on making a lifestyle change? 88% of people said, yes, after attending one of these talks, I plan on making a lifestyle change. Obviously, what people say they'll do and what they actually do is very different. So we call them back up in 3 months and say, hey, did you actually make the lifestyle change? And did you sustain that lifestyle change for the past 3 months? 48% of them said yes. So video conferencing, for us right now, we use it fairly commonplace. When we were first starting, we were trying to determine, is video conferencing actually an effective way to teach people? Our third major program is our opioid overdose prevention program. And the goal of this one is to provide education on what is the opioid crisis, the opioid epidemic. We've included testimonials by individuals recovering from opioid use disorders, and we discuss treatment options. And then we train individuals on how to recognize an opioid overdose, administer naloxone, and then perform rescue breathing and hands-only CPR. And then we also distribute free naloxone kits at these events. As you can imagine, COVID has impacted this program. We can't have these sort of large gatherings and presentations anymore. So what we've been doing instead is we've been training members at the food pantries, I see Sandra is here, to actually to train members of the food pantry lines or members of the community on how to use this. And then we've given them the kits to further distribute. So we've had to adapt to COVID, but we're still able to get these free kits out to the community. In total, we've had 213 events since March of 2018, and we've trained 67 volunteer medical, nursing students, as well as staff to actually go out into these communities and train people. Community members wise, we've trained, at this point, I think we're closer to 3,000 community members, and the vast majority of them are non-Black Latino, 59%, or African American, 21%. And the reason for this is that the two most heavily impacted communities by opioid overdose deaths are East Harlem and the South Bronx, which are predominantly Latino, or Latinx rather. To date, the program has collected 48 overdose reporting forms. So these are forms where people say, hey, I used the kit and potentially saved a life. This based on data is strong underreporting due to the stigma. So we're actually working with a company to do a research study to actually anonymously track when these kits are used to give us a better idea of what percentage of these kits actually end up being used. But to date, we've distributed about 5,600 naloxone kits. At this point, we're probably up to 7,000. And then finally, I want to talk a little bit about the COVID-19 vaccine sites we've been operating. And so obviously the big health crisis over the last year and a half has been COVID-19. And one of the ways that we've been trying to help out is to use our community network and our partners to open up vaccine sites in underserved communities. And so we partnered with a group called Community Healthcare Network. They're a group of federally qualified health centers. as well as the Hunter College School of Nursing, NYU, and LIU. And we opened 4 vaccine sites at faith-based institutions across New York City. So they're the Convent Avenue Baptist Church in Harlem, the Fort Washington Collegiate Church, that's in Washington Heights, the New Jerusalem Worship Center in Jamaica, Queens, and the Church of God in East New York. And at all of these sites, the vaccines were administered by voluntary faculty, staff, and students from the partner institutions, but everybody else working at the site. So all the administrators, the flow monitors, people doing the check-in were all hired from the church and the surrounding neighborhoods. And the reason we did this is we felt it was very important that, yes, we can provide the medical, personnel to administer the actual vaccines, but the people who will be interacting with the community members, the people who should be running the sites, should be the people from the churches and the community that are hosting these sites. And that's one of the ways that we were hoping to get through a lot of the vaccine hesitancy and concerns. It's a lot easier for individuals to go to a church that they're familiar with, where their clergy member is, to get the vaccine than it is to some sort of large vaccination site, like the Yankee Stadium where the Javits Center was. And then starting in June of this year, we actually added some of the heart-to-heart health screenings at the sites that the Weill Cornell CTSC supported. And there's a quick overview. To date, across the 4 sites, we administered about 22,600 doses. And that's interesting and for several ways, because one is that these sites were, the communities these sites in were actually heavily under-vaccinated. And what I mean is that only about 40, at the time that we pulled this data on July 26th, only about 45% of individuals in the communities that we had these sites at were vaccinated. New York City wide, it was 56.7% at that point. And so this was a huge discrepancy in vaccination rates. Yet by sort of the end of the project, we had actually very little demand from the individual community to host these, which is why we were shut down by FEMA, because there were not enough people coming to these sites. And then we did take a look at the race and ethnicity. And so that's one thing we're extremely proud of, is that if you look at nationwide sort of the vaccination rates, you can see that it's majority of the US population is white. But if you look at the ethnicity of the doses administered at all of our sites, which is the second column, you can see it's heavily Hispanic, African-American are being represented there. And so the other 4 columns are the individual sites. So East New York, Harlem, Washington Heights, and Jamaica. And so you can see it's pretty consistent across all the sites that it's all heavily serving minority populations. And so we feel like we did a very good job in meeting that goal of directly serving the people of these communities. I know early on there was a lot of concern, hey, you're just gonna have a bunch of rich white people show up in their Mercedes and get the vaccines at your sites. We actually took steps against that, where we gave the churches themselves the ability to book vaccines from their community before we opened it up to everybody else. So that was one of the caveats we had with FEMA that we said that if we're going to do this, we have to ensure that the communities, these sites are going to get priority first. And then lastly, I wanted to talk about our community research pipeline. And this is our goal of fostering the development of new community-engaged research projects with an emphasis on community-led projects. So it starts out with something like this, where we educate community members about what is research, and hopefully get some of you interested in participating in the research process in the future. We also do the same with our investigators, so our physicians and our researchers, and we teach them about how to properly do community research and best practices. Then afterwards, we have what are called community planning grants. So these are small grants we give for community organizations to find an academic partner and design a research study. And then once they've designed it, they can apply for a community engagement pilot grant to actually conduct that study. And then finally, I want to talk about the CTSC's Community Advisory Board. It currently consists of community members from all across the city with a large diversity of race, gender, communities, and boroughs being represented. Most of them are, about 86% are either female or minority members. And the participants include faith-based organizations, local government, daycare, community advocates, and other not-for-profit health organizations. And starting in 2017, the Community Advisory Board began reviewing CTSC planning grant applications and then expanded the community pilot applications. And then starting in 2019, the CAB actually started reviewing all the pilot applications received by the CTSC. We've slowly expanded it to, initially it was just a small portion of it. At this point, this year, it was all the ones involving human subjects was scored and reviewed by the Community Advisory Board. And they're scored in the same format and given the same weight as the scientific reviews. And with that, I will open it up to any questions. Feel free to unmute yourself and talk or type in chat. Happy to use either.
Yeah, if anybody's shy, I wouldn't mind reading your questions in the chat.
Greetings. I'm not shy. I always give a little bit of pushback with that term hesitancy. I haven't met anyone who's hesitant, but I have met people who are knowledgeable and aware of the lying, cheating, stealing, and reputation that we have. So we are conscious. But I think the news media likes that word hesitancy, and I haven't met anybody that's hesitant.
Yeah, I know. I think, yeah, you're definitely right in that. I mean, one of the big questions that I got asked for the sort of the female-run vaccine sites is, why is it that you think that these communities, that people just stop showing up to the vaccine sites of these communities? And a lot of it is, as you can say, is that, how the media portrays it is different from what I hear from what's on the ground. There's one individual I know that I've talked to community leaders at every all these sites, but I know there's one individual who's actually running, I guess, security guard for one of the sites. And he told me that, for him, he's never interacted with a healthcare system his entire life. And the only reason he got the COVID vaccine is because one of his family members caught COVID very early on last year and passed away from it, unfortunately. And he said that scared him. And so he said, though, but for me, I had this experience and I tell everybody who comes here my story and encourage them to get the vaccine. But he said, there are a lot of people in my community who are like me who have spent their entire lives being ignored by the healthcare system. We haven't been accepted by it. It doesn't want us. It doesn't want to treat us. And I've never gotten any other vaccine in my life, he told me. So for a lot of us, the question is, why is the healthcare systems all of a sudden interested in us coming and applying to their services when they've never wanted us in the past to do so? So of course, that generates suspicion. And that's because, unfortunately, America's healthcare system is largely for profit, and it has not bothered with, treating what they call unprofitable patients. And it's a huge error in the way that we do healthcare in the United States. And it's something that, we're trying our best to change. And that's why when we went to these community sites, we made sure that community members given access first, and we hired members of the community to help to run all these sites. And so back to that sort of original question of, hey, why do you think people stop showing up? I think a lot of it at some point is that you've reached most of the people that are willing to do it. And after that, you have to start talking to individuals one-on-one and address their concerns and explain it to them. And unfortunately for the government, that was not sort of something they were willing to fund. A large effort to talk to people one by one. They did not necessarily consider that an efficient use of resources. So we ended up shutting down the sites. But no, we've reached the difficult part of the vaccination campaign, unfortunately. Most of the people who are willing to get it and don't have concerns about getting it, we vaccinated. And now it's the people who may be willing to get the vaccine, but may just need the concerns addressed. And unfortunately, that's a very labor-intensive, boots on the ground, so to speak, effort in these communities that needs to be undertaken. Hopefully that answers your question, Michael. Any other questions?
Okay, thank you so much, Jeff. That was very informative and very insightful. Thank you so much. Now we're going to have Ms. Barbara Hormann. She's the adult nurse manager. She has over 31 years of experience here at Weill Cornell Medicine, Clinical Translational Science Center at NYP, New York Presbyterian Hospital. In addition, she is the co-founder of My Empowerment Place, which helps empower parents and children who are stressed through holistic methods and harnesses the power of healing through Reiki sessions, sound healing, stress reduction workshops, sleep, aromatherapy, meditation, and mindfulness. So the next voice that you're going to hear is Miss Barbara Hormann. Oh, okay.
Hi, everyone. Thank you for your time and hope you're enjoying the class so far. Can you see my screen? Okay, great. All right, so I'm going to be talking, Jeff touched on it a little bit on one of his slides, but I'm going to go a little more in depth of the phases of the clinical trials and talk to you about what the nurse's role is in these clinical trials. So phase one is the first phase any drug goes through prior to hitting the market. And these are the first in human studies. More than likely, they've been done in animals prior to getting to a human. But phase one is the first time that a human being has ever gotten this drug. And it's usually done in a small number of normal volunteers. So if you're young, healthy, you don't have to be exactly young, but as long as you're healthy and don't have any diseases or anything that the study says you can't have, you can volunteer to get one of these drugs. Or it's done in a disease-specific population. So they, more than likely, they're not going to test cancer drugs on normal volunteers. They're going to test that on patients that have cancer. And these are usually done in a very controlled setting. So in a hospital like we are, or in a facility that only does these these phase one trials. They are research centers that only do phase one trials. And participants are watched very, very closely because safety is the main concern. These drugs have never been given to humans before. So we're keeping a very, very close eye on these people who are getting these drugs. And the purpose is to find out how the body reacts and how the drug reacts in the body. So if somebody has an allergic reaction, if it's just one person, we'll attribute that probably to that person. But if multiple people have that reaction, that's going to send up a red flag that something is wrong with this drug and causing somebody to have that allergic reaction. Yeah. And it's very unlikely that the person getting the drug will have any benefit from this drug. They're normal volunteers or they have a disease, but it's a very low dose perhaps, or they're only getting it once. So there's very unlikely to be any change in the person's condition based on that drug. And I said that already. We start at a very low dose and increase as the study progresses. And this phase can last a few weeks to a few months. And then the drug company or the drug company or the doctor, if the doctor is running the study, will analyze the data and see what's going on. And if all goes well with that phase, the study goes on to phase two. And this phase hopes to answer the question, does this drug or treatment work? So in that phase one, we were just seeing if it was safe. Now we are looking to see if this drug will work for anybody. And this is continued testing as a randomized control trial. So this means that somebody may get the drug or they may get placebo. The FDA really likes those placebo-controlled trials to prove that the drug has an effect, because I think people, or hopefully people have heard of that placebo effect. You get a pill or a shot that don't have any drugs in it whatsoever. And there's something called a placebo effect that can change the condition or whatever. Because our minds are so powerful, if we believe something's going to work, chances are it may work or may show an effect. So they do like to have those placebo-controlled trials. And this phase 2 studies are done in a larger number of participants. So there'll be many more people that have the disease or normal volunteers included in this study. And as I said earlier, this is testing to see if the drug is working as the drug company says it should. I talked about that already as well. Placebo, or this phase can be tested against a standard of care. So say we're doing this on multiple myeloma. This is a new drug for multiple myeloma, which is a type of blood cancer or cancer. So this new drug will be tested against a standard of care, a drug that's normally given to multiple myeloma patients, to see if it's any better or any worse than the treatment that's already given. And this is typically done at random. So the drug company will say half the people will get our new drug, half the people will get the standard of care, or it's done on if there is a placebo, a third of the people get placebo, a third of the people will get this drug, and a third of the people will get the new drug. And there may or may not be any therapeutic effects at this stage. And the dose may be the same for everybody, or they may lower the dose or raise the dose based on, there's different phases within this phase 2 trial. And this phase can last a few months to a few years. So that's part of the reason why if a drug starts in clinical trials, it can take years and years and years for it to get to market. There's so many hoops that the drug companies they have to go through. And I was shocked when I read this statistic. Only 18% of drugs go on to the next phase, which is phase 3. So a lot of drugs. So almost 80% of the drugs don't go on past this phase. And phase 3 is answering the question, is this drug or treatment better than whatever is considered gold standard? So in phase 2, they can do it against standard of care, but they don't have to. This phase is definitely done against standard of care, if there is one. So many sites across the country or across the world are doing these randomized controlled trials. And this is done in even more amounts of people. And normal volunteers aren't typically included in these phase 3. They're giving it to that targeted population that have the disease. And as I said, it's done across, it can be done in just the US, it can be done just in Europe, or it can be done in many, many parts of the world. These typically are done at a hospital, or these, because we've got lots of experience with it in humans, they can be done in doctors' offices, which are a much less controlled environment. And this can be done with a placebo as well, or against that drug that's known to work. And the main point of this phase is to test effectiveness, to see if this drug really works. And this is the pre-marketing phase. So this is the phase just before the FDA is going to say yes or no. So it will more than likely go onto the FDA after this phase is completed. And these can be extremely expensive to run because the drug company is typically giving away this drug for free to thousands and thousands of people. And this phase can also last a few years. And as I said, the FDA application is that next step. So their drug companies are working on that application at this time. And about half the drugs that make it to phase 3 are successful and can be approved. And the last phase is not heard of too much. It's a phase 4 study, and it's typically a post-marketing. So this has already been FDA approved, and the FDA is asking the drug company to get more information on it. And they may think it needs more information for safety or for efficacy, which means if it works or not. So they are asking questions, what else do we need to know about this drug? And things that are looked at this point are quality of life. So is this drug work, but because it needs to be given 4 times a day, people aren't going to take it because it really affects the quality of life, or the injection site hurts too much, so we don't think people will take it. And look at cost effectiveness. Is this going to be too expensive for insurance companies to pay for, or if somebody doesn't have insurance, if it's going to be too expensive to pay out of pocket? They're also looking at long-term side effects and the benefits of the drug. And at this phase, they may compare 2 different FDA-approved drugs to see which one works better. And it's done to prove that this drug for one disease works for another disease. So this phase 4 can be done to add a new indication for a new drug. So an example is Viagra. Viagra is really a drug used for pulmonary hypertension. And they also found that it worked for erectile dysfunction. So I don't know if Pfizer, I think Pfizer's the drug company, if they have that on the label or if it's used off label, but if they wanted to add erectile dysfunction to the label, they would need to do a phase 4 study on it. And this is done in lots and lots of people over a very long period of time, especially if they're looking for long-term side effects. And if there are harmful side effects, like a couple of years ago, some of the pain medicines had side effects and they were pulled from market. So the FDA could say, there's been too many side effects. We're pulling the drug from market during this phase 4 study. And the nurse's role in clinical research is really to be a patient or a subject advocate. I don't know if any of you have participated in research studies, but the consent forms can be quite lengthy. And if somebody has a disease and they hear a new drug may help them, they may not take the time to read every single line of the 25-page consent form. So our role is really to make sure that the patient or the subject or the participant understand what they're getting involved with. It could be multiple blood draws. It could be staying in the hospital overnight. It could be that EKGs need to be done multiple times. So we're doing a lot of data collection. We're also observing for response to that drug therapy, looking for side effects. Somebody may not think that a side effect that they have is worthy to tell us because it was so slight, but we need to know every single side effect of that drug. I like to think of us as the gatekeepers. If the doctors want to draw extra blood because they have a new idea, we're going to stop them if it's not part of the original protocol. We really make sure that the protocol is followed to the letter of the law, per se. And some nurses, it doesn't happen in our site, but some nurses can be co-investigators and can obtain consent and determine if somebody is eligible to take part in a study. So we have, I think, a very important role in clinical research, making sure that everything is going smoothly, we're following the protocol, and that the subject or the participant is safe. And that is the end of my presentation. If anybody has any questions, I'd be happy to answer.
So thank you, Ms. Hormann. It's a great presentation. I actually caught something that I didn't learn the last two series, so.
Terrific.
I don't see any questions in the chat, but anybody's feel free to just jump right in.
In that role as the nurse, do you ever have a problem with being so honest, clear, and fair that the doctors view you in any particular light?
Sometimes if we tell them we can't draw that extra blood, they get a little angry at us, but when we explain to them why, because the consent form has lots of details in it. So the consent form says we're going to draw 3 tablespoons of blood. And if they're adding extra blood, we're going to go over that 3 tablespoons. So we're not following the consent form. So once we explain it to them, and they basically understand. And our role is, if these people are volunteering to come to us, and if they say they don't want to participate any longer, that's fine with us. There's no coercion to say, oh, you signed the consent form, you have to stay, you have to, get your blood drawn, or you have to get this done, we have to do this. There's none of that. Our role is to say, it is your right as a participant to say you no longer want to participate. And the consent form says that very clearly as well. And it also says that your care at this institution will not be compromised if you decide. Some people are afraid to say, I don't want to participate anymore, because they're afraid their doctor is going to be mad at them, or they won't get the same level of care, retaliation may occur. So our role is to assure them that none of that will happen. Everything is above board. They will be treated the exact same way if they say no.
Is there any benefit offered to the participants for participating, like in insurance or?
Not so much insurance,
free
but
care?
yes, it depends on the study. Most of the drugs, unless they're really, really expensive, are given to the participants free of charge. And anything typically that we do in our unit there's no charge for. The drug company may be charged. The investigator may, or the drug company may reimburse us for our time, but typically in the early phases, there's no charge. In phase 3 and phase 4, if Medicare will pay, most insurance companies will pay for the drug. But to answer your question, yes, some participants are given money to participate in the study. So we do a bronchoscopy study on normal volunteers. They are paid to come in and do these studies. Most phase 1 normal volunteers, there's no reason for them to come in and get the drug unless they're doing it for purely existential reasons. They're going to be paid for participating in their studies. Typically, people that have a disease aren't paid.
Is there any like regulatory agency that do audits to the studies?
Yes.
And, check to make sure participants were treated correctly and
yes,
not abused?
Our institutional review board does not for cause audits of our studies, and every consent form has a spot in there that says who to call if you have any complaints. If it's a drug study, the FDA can come in and do audits. The FDA is not so much looking at the way the participants were treated. They're more looking at, was the blood drawn on time? Was the right dose given? So it's more our institutional review board that does those type of audits.
Any side effect that's caused to the participants? Are they like, taken care of or, helped with that after the study is done?
Yes. Every consent form has that information in it as well. If the life-threatening injury happens or an allergic reaction happens, they're brought right down to the emergency room. Some of the drug companies pay for any medical costs that are involved if there is an adverse reaction. Typically, they are not paid for an adverse outcome, but their medical care is covered.
Okay. I mean, hi. Felix Rojas here. Hi. That was actually the question I was about to ask, because you got, let's say, side effects. And I was just thinking, but I guess the answer was, the question was answered already. Like, in terms of side effects, like how those participants going to be taken care of, what is the legal ramifications of that, like legally and healthy wise?
They are completely taken care of.
Oh, all right. That's the question. Thank you.
Yeah.
Barbara.
Good to know. Good to know.
Yes, Lula.
Barbara, this is Lula. There was a couple of words that you threw around, and maybe some people are not that familiar with them. Bronchoscopy, what it is, and the Institutional Review Board and the FDA.
Sure. So a bronchoscopy is a study where, like an endoscopy, a tube is put down your throat and the doctor looks in your lungs. So our pulmonologists do this bronchoscopy study on normal volunteers, collecting samples of normal lungs because they're doing cystic fibrosis studies, or they're doing different kinds of studies. So they're collecting normal lung tissue. So that tube is put down and they take samples of the lung. And that is one that's fairly invasive, which means we're entering the body. So those participants are paid for that. The FDA is the Federal Drug Administration. They're the body in the US that approves or disapproves drugs and monitors side effects. So they're kind of it for drugs. And the IRB, or the Institutional Review Board, is the ethics committee for protocols. So any protocol, any study that takes place at any institution has to go through an institutional review board. I've been on our hospital or college's IRB for more than 25 years. So it's made up of doctors, nurses, other scientists. There's a community member on there. We have some ministers on our IRB, and we review the protocols for the science, for the ethical view of the study. Not so much for the science. We do look at science as well, but it's more making sure that the participants are being treated fairly, that they understand the risks and benefits of the study, and that it's in the consent form very well laid out. In the syllabus that you got, the Tuskegee study was listed there. So the Tuskegee study would never have passed any institutional review board. That was done prior to any institutional review boards coming about. So some hospitals call it the IRB, or the Institutional Review Board. Some places call it the Ethics Committee for research. So any study that is done in animals or humans does go through that rigorous review process.
And the IRB is part of the institution that running the study, right? Every institution has their own.
They do,
IRB.
and there are also independent IRBs as well.
And those are probably commissioned by the institution or by somebody else that want to know how things went on.
I'm blanking on the regulatory body, but there are standards that any institutional review board has to meet. You know, there has to be doctors on it. There has to be scientists on it, whether it's a doctor or a nurse. It has to have that community member. So there are regulations, federal regulations that state who has to be on that board. So whether it's here at NYU, at that independent IRB, there's a standard in the US that has to be met.
And that's established by the FDA, I suppose.
I just read this and I'm blanking on the regulatory body that.
It's fine. I mean, the FDA does regulate most of those drugs.
Right.
So I figure, okay. All right, very good.
And there are accrediting bodies. I don't know if any of you have heard of the Joint Commission. They are an accrediting body for hospitals. There is an accrediting body for institutional review boards, and our institutional review board is coming up on a survey. So we are going for accreditation, which is just kind of like a gold seal on our program.
Yeah, so to clarify, so the IRBs are regulated by the Department of Health and Human Services.
Okay, thank you, Jeff.
Okay, does anyone else have any more questions? I want you to know in the upcoming classes, we're going to be talking a little more about the institutional review boards. So you'll get more information about that. We will be also talking about the preparation for people to join clinical trials. We'll hear more about that, more about the phases, more about safety and the consenting process, because Barbara made it sound quick and simple, but the consenting process, Barbara, she knows, takes some time. And that's part of what Barbara does all the time. So I want you to put your questioning hats on, review the material in the syllabus, take a look at it, and go over it and get prepared for next week. And if you have questions, write the questions down. And if you have more questions, if anyone have more questions for Barbara or for Jeff right now. So I want to thank all of you. And I want you to know that you will be getting questions about there's right and wrong answers, yes, but you can do the test as many times as you like. So there'll be questions that Agnes will be sending to you. There are not that many. You'll get 5 for each speaker. And I know that you will do well. But if you have questions, write them down. If you need clarification of something, write them down as well. So I thank all of you so very much for attending today. If you have last remarks, Jeff, Barbara, any comments, last comments?
I have a question. I just have a quick question. I forgot, I don't know. Are we getting the video or the recording for this?
Yes.
So we can just listen to it again if you wanted to.
Yeah, so I'll be sending the recording of today's session along with the questions. The questions will be taken on Google Forms. So you can take it as many times if you like. If you get a question wrong and you want to repeat it, up to you.
Hi, a quick question about the videos that we're gonna watch. Are they being sent through email? The syllabus?
They're on the syllabus. They're on materials to review. Did you receive the syllabus?
Not yet.
Okay, I'll make sure I'll resend the syllabus along with the recording and the questions to take. So everybody should have all the information. But if you're missing anything, please feel free to reach out to me also.
Yeah, I know some people just joined today, so you may not have the syllabus. So just let Agnes know, even before you get off the line, let her know, so that way you can have a copy of the syllabus. So you'll be able to formulate your questions and get a greater clarity on the material that we're going to cover.
Yeah, when you get the syllabus, you just have to click on the link and it would take you to, if you have an online, you have online access, so internet access. Click on the link and it should take you to the YouTube video.
All right, right. I just have to check the email.
Okay.
But anything, I'll let Miss Agnes know, and she might send this again.
Okay, so then I thank all of you so very much for your time today. I hope you are coming away from this program with more information than you had when the program started. I thank our speakers for sharing their time with us today, and I thank all of you for sharing your time with us today as well. I want to say you just be blessed, have a great week, and looking forward to seeing you back here next Thursday at the same time.
Enjoy the rest of your classes, everyone.
Thank you. Yeah.
Bye.
Thank you.
Thank you.
Have a blessed
Bye-bye.
weekend. Have a blessed
Looking
weekend,
forward
everybody.
to next one.
Thank you.